Hi everyone, good evening. Welcome to the FMGE Jan 2025 recall session. And let me start the session by telling you all that the questions that are discussed in this PowerPoint are purely recall based. And the motive of this live session is to get the actual questions asked in the exam. The final questions received after discussion will be uploaded on the PrepLadder app. But still, we have done our best to recollect and to help students recollect all MCQs. Okay. And before we start the session, I'm very sure you're all relieved after the exam, right? So all that you're expected to do now is leave off all the stress that you have been carrying so far, and just to have an open mind and have a look at this video to get to know the answers for all the questions that are asked in the biochemistry part. And an overview of this session is, yes, there were 20 MCQs in biochemistry. And out of these 20 MCQs, clinical biochemistry MCQs were the majority. 6 of those were from clinical biochemistry, that is excluding inborn error of metabolism. So 3 MCQs from inborn errors of metabolism. From vitamins, as always, there were many questions, 3 questions. Alcohol metabolism 2, genetics 2, and then remaining 1 each, minerals, chemistry, and metabolism. So I have put this up as a slide only for you to understand how essential it is to learn biochemistry in an applied manner. No more questions are asked in the chemistry part or in the pure metabolism part. Most of the MCQs were applied in FMG Jan 2025. So if you are a person who's preparing for the next FMG exam, please learn biochemistry in an applied fashion. Yes, it is almost transforming to USMLE kind. Hi, Shivam. Yes, for sure you can attend the session. You'll be able to answer many MCQs here. Okay. So with that, let's start discussing the MCQs one by one. Hi, Deepu. Yes. So which of the following is excreted in the urine of patients with pentosuria? Yeah, pentosuria, pentose gets excreted, which is L-xylulose. Because we know in essential pentosuria, the enzyme that is defective is xylulose dehydrogenase, right? Vitamins A, B, less questions. Yes, 3 MCQs and vitamins. So the carbohydrate that is excreted in urine in patients with pentosuria is L-xylulose. Hi, Aradhana. The next one is good evening, Dr. Idiopathic. I like your name. A baby presents with the clinical feature shown in the image. So what do you see here? Can you see that there is history of diarrhea, and then there are rashes, periorificial rashes, right? So this is acrodermatitis. Periorificial rashes is acrodermatitis enteropathica, which is caused by which deficiency, all of you? Zinc deficiency. Okay, answer is choice A. Very good. This one, it's a very simple question. Gum bleeding. The moment you see gum bleeding, what should come into your mind? Scurvy. So patient presents with gum bleeding, petechiae, poor wound healing. All these are features of scurvy caused by vitamin C deficiency. Because we know vitamin C is necessary for collagen cross-linkage formation. When there is no collagen cross-linkages, all subendothelial connective tissue becomes weaker, and that is why there is gum bleeding and there is poor wound healing. Very good. Yes, Shivam the Great, you're right. Rachit, you're also right. So answer is vitamin C. Yeah, vitamin C is also an antioxidant. So with respect to vitamin C, there were 2 MCQs. Both were very simple, straightforward MCQs. So if you ask me how was the paper was conceptual. Most of the MCQs were based on previous year topics, right? It might not be an exact repeat of previous year question, but most of the topics have been already asked. So answer this, which of the following enzymes is dependent on vitamin C for its activity? Vitamin C is necessary for hydroxylases, prolyl hydroxylase and lysyl hydroxylase. Dr. Raj, it is not lysyl oxidase. Lysyl oxidase is dependent on copper. But the question is here on vitamin C. Vitamin C is necessary for prolyl hydroxylase and lysyl hydroxylase. P square facts. Hi. So the next question. So it's very simple image-based question, right? What is the image that is shown to you here? Bow legs. And they've also given you a 2-year-old child presents with bow legs, normal calcium, high parathormone. The probable diagnosis is vitamin D deficiency, which is rickets. Right? Answer here is choice B, rickets. I've already told you whenever there is vitamin D deficiency, of course, there will be initially low calcium and low phosphate. But whenever there is low calcium, there is secondary hyperparathyroidism. Low calcium stimulates parathyroid gland to release more hormone. So what will you observe? Secondary hyperparathyroidism. The secondary hyperparathyroidism increases calcium reabsorption. That makes the calcium level to become normal. So I've already told you this. In vitamin D deficiency, calcium levels most of the times will be normal. But parathormone causes phosphate secretion. So phosphate levels will be low. So what is your diagnosis here? The diagnosis is rickets. So X-ray picture. Okay, even X-ray would have shown you what? Bow legs, right? So bow legs with normal calcium, high parathormone is vitamin D deficiency or rickets. Was it tough? So the next question, a patient presents with arthritis. The arthroscopy reveals blackening of the joints. So I've always told you, don't appear for an exam if you had not learnt about alkaptonuria. I say that on a lighter note, right? Because alkaptonuria is quite common in India. So FMGE paper most of the times has got an MCQ on alkaptonuria. So arthritis presenting with blackening of the joint is alkaptonuria. Alkaptonuria is because of the defect of homogentisate oxidase. Very good, Shivam, you're right. Branch chain keto acid dehydrogenase defect causes maple syrup urine disease that does not present with blackening of the joints. Tyrosinase defect causes albinism, right? Albinism is lack of pigmentation. A 4-year-old neonate presents with a bilirubin of 15 milligram per deciliter, the most probable causes. So here the clue that is given to you is forte, and bilirubin level being equal to or less than 15 milligram per deciliter would be physiological jaundice. Okay, so the answer is, question was ferric chloride test positive. Okay, so euchronosis, ferric chloride test will be positive, right? Because of the feedback inhibition, whenever ketones accumulate, ferric chloride test will be positive. Okay. So what is answer here? The answer here is physiological jaundice. So what is that? We have discussed already about physiological jaundice. Physiological jaundice does not present before 24 hours after birth. So if you see jaundice before 24 hours, it's definitely a pathological jaundice. And physiological jaundice peaks on the 4th day. And even at the peak, it does not cross 15 milligram per deciliter. So the answer here is physiological jaundice. Breastfeeding jaundice. A patient with a history of breast milk jaundice. Okay, if there was history of breast milk, that becomes more an evidence for it to be a physiological jaundice. Okay. A patient with a history of strenuous exercise skipped a meal and later consumed alcohol at a party. Alcohol inhibits no such option. Okay. There was no Crigler-Najjar syndrome type 2. Okay. So alcohol inhibits which of the following biochemical processes potentially leading to hypoglycemia? Have we discussed this? We have discussed this so many times, right? Chronic alcoholism makes a person prone to develop hypoglycemic episodes. Because whenever alcohol is metabolized, you see high NADH-NAD ratio, right? When alcohol is metabolized by alcohol dehydrogenase and by aldehyde dehydrogenase, there is high NADH-NAD ratio. So all pyruvate would become lactate. All oxaloacetate would become malate. There is low pyruvate and low oxaloacetate, which means gluconeogenesis cannot happen. So what is the reason for, very good, what is the reason for hypoglycemic episode? Because gluconeogenesis cannot happen. What is the reason for gluconeogenesis not being able to happen? It is because of the high NADH-NAD ratio causing low pyruvate and low oxaloacetate. Okay. Yes, LRR. Yeah. So many questions were discussed in the LRR session. I discussed in detail about alcoholism in the LRR session. Remember? A 45-year-old chronic alcoholic presents with anxiety. This is an exact previous year question. I won't even say previous year topic. The exact MCQ in the sense chronic alcoholic presenting with tremors, global confusion after 48 hours. What is it? It is delirium tremens. Thanks, Pitch Plus. I'm happy that you got benefited by watching LRR. So what is answer here? Delirium tremens, because there is history of alcohol withdrawal for 48 hours, after which the person presents with anxiety, tremors, and hallucination. Exact question, yes. Which of the following amino acids primarily acts as a buffer? Yes, I understand your anxiety, Vansh Rathod. I also did not expect them to ask you about mucopolysaccharidosis type 9, right? They've never asked you about mucopolysaccharidosis type 9. That is why when I started the session, I did not say all MCQs were discussed, right? Still, what I want to tell you all is, in any question paper, there will always be like 20 MCQs, which are like out of the blue, right? You would not expect those 20 MCQs in any exam, in any examination. So consider that MCQ is one of those 20. Even if you don't answer that MCQ, you will be able to clear FMGE paper. Okay. Yes, I understand, Saurabh. So what is answer? Which of the following amino acids can act as a physiological buffer? It would be histidine, right? This also was discussed as a one-liner. pK of histidine is 6, which is close to the physiological pH of 7.4. So histidine acts as a physiological buffer. Which of the following is deficient in mucopolysaccharidosis associated with Natovich's disease, right? So the enzyme that is deficient in Natovich's disease, which is mucopolysaccharidosis type 9, is hyaluronidase. So which mucopolysaccharide would accumulate in this condition? Hyaluronic acid. Okay, answer is choice D. During starvation, which of the following hormones is primarily produced to maintain blood glucose level? This is a very simple question, and in all LRR sessions, I've always started metabolism with this simple fact. So in the well-fed state, when blood glucose level is high, insulin is released. During starvation, when the blood glucose level is low, glucagon will be released. So what is the answer? The answer is glucagon. Option ruled out. This was not the question. Zishan, I will be happy to get the question from you. Please type it in the chat box. During starvation, which of the following hormones is primarily produced to maintain blood glucose level? The answer is glucagon. First, which hormone is released? First is glucagon, always counter-regulatory hormone, right? So I've also told you the sequence: glucagon, growth hormone, norepinephrine, and finally it is cortisol. Okay, glucagon, growth hormone, norepinephrine, and cortisol. The development in jaundice question, there was low urine output of baby, and one of the options was the mother is not feeding the baby properly. Okay, even then I would say it is physiological jaundice, right? Based on the history that is provided otherwise. Another question was like, which hormone during starvation will keep? Yeah, that's the question that I discussed, right? It's glucagon. Cortisol and epinephrine, Vansh Rathod, even if there is cortisol and epinephrine, the first hormone to be released would be glucagon. Okay. So this is again a question that we have already discussed. The development of cataract in patients with diabetes is because of accumulation of what? Sorbitol. Because in diabetes, there is hyperglycemia, excess glucose enters into lens, and lens has got an enzyme aldose reductase, which reduces the aldehyde group of glucose to form an alcohol, and that alcohol is sorbitol. Had it been galactosemic cataract, it should have been dulcitol. Okay. Yes, snowflake cataract. What is the primary mechanism behind tissue damage in long-standing diabetes? So I've told you this also. Chronic complications of diabetes is explained by excess glucose that enters into those cells which don't depend on insulin for glucose uptake. Have we discussed that? Right? So what happens when excess glucose enters into those tissues? That glucose gets converted, or glucose forms advanced glycation end products. And these advanced glycation end products are responsible for chronic complications of diabetes. So what is the right answer? The right answer would be hyperglycemia. So how many of you answered this right? A patient presents with a history of vomiting. This question was not that. Which question was not that? This one? Okay, then let's exclude this. Physiological jaundice was not in the option. Okay. What was that? Question was a person with severe hypoglycemia and 20 times vomiting. What is the first step? I don't think that was the question, Varun Gard. Injection glucagon, decreased insulin, normal saline. What is the first step? I wouldn't inject normal saline to a patient who's severely hypoglycemic. Yeah. So what is the answer here? The answer here is, I think I'm right because urine output was low. So history of vomiting, arterial blood gas analysis reveals the following. What is the pH? This question was given, right? Because I'm very sure that the student who gave me this question was 100% sure about this question. pH 7.5, which means it is alkalosis. And alkalosis, PCO2 is high. High PCO2 cannot explain alkalosis. High PCO2 can only explain acidosis. So this is not the primary acid-base disorder. Bicarbonate, normal is 24. In this case, bicarbonate is elevated. So high bicarbonate has caused alkalosis, which is metabolic alkalosis. And in LRR session, I also explained you why vomiting causes metabolic alkalosis. Remember, when there is vomiting, there is hypochloremia and there is dehydration. Both hypochloremia and dehydration causes secondary hyperaldosteronism. I'm explaining you this because there was another question on primary hyperaldosteronism presenting with metabolic alkalosis. Remember, Conn syndrome. So aldosterone causes sodium and water reabsorption. Reciprocally, it causes potassium and H plus secretion. So because it is secreting potassium and H plus into the renal tubule, the person is losing potassium, losing H plus. That causes hypokalemia and alkalosis. So what will be the answer? The answer would be metabolic alkalosis. Okay, very good. Answer is choice A, metabolic alkalosis. A hypertensive breast milk induced jaundice. So if there was history of the mother feeding the child and there is jaundice, then I would go for breast milk induced jaundice. You're right, Dr. Raj. Very good, Karo Sensei. Yes, you're right. So this is the question that I was telling you. A hypertensive patient presents with hypernatremia. All of you tell me if this question was right. There was hypernatremia, hypokalemia, and metabolic alkalosis. What is the most likely diagnosis? I've told you whenever there is a case-based MCQ, always exclude choices. So how can you exclude other choices? I would not think of Bartter syndrome or Gietelman syndrome because in this case, the person has normal blood pressure or low blood pressure. They don't present with hypertension. Okay. And how about Addison syndrome? Addison syndrome is lower adrenal cortical hormone release. So when aldosterone is not secreted, what do you expect? Sodium will get lost. So they present with repeated episodes of hyponatremia and hypotension. Because it is hypertensive patient with hypernatremia, hypokalemia and metabolic alkalosis, what should be your answer? The answer should be Conn syndrome. Very good, DXMDD. I'm happy for you. By fluke, you have chosen the right answer. The right answer is Conn syndrome because of few reasons. One is high BP, hypokalemia, metabolic alkalosis. Which of the following enzymes is typically elevated in prostate cancer, right? Another simple question, it is acid phosphatase. So prostate has got acid phosphatase in the cytoplasm. So whenever there is prostate damage or whenever there is prostate metabolism that gets affected, acid phosphatase level will be elevated. 8-year-old child presents with obesity and developmental delay. It is caused by paternal deletion, right? What is it? Prader-Willi syndrome. So we have learned Prader-Willi syndrome, those children present with excessive appetite, obesity, short stature, and developmental delay. And Prader-Willi syndrome is characterized by paternal deletion. Do you understand? It's characterized by paternal deletion of which part? Very good. Chromosome 15. Right? Answer is choice C. Good. A child presents with, did you see this MCQ? A child presents with micrognathia and low-set ears. These clinical features are commonly associated with which type of genetic abnormality? What is answer? Deletion. Yeah, answer is deletion. So I don't know if this question was asked or was this question a part of this one. But if this was the question with micrognathia and low set ears, you should go for deletion, which is the most common type of abnormality that presents with a syndromic manifestation. Okay, so answer is choice A. So that's all about the 20 MCQs. And I also remember one more MCQ. I think they had given mountain sickness, right? Mountain sickness, a person is given a drug. And this is also a previous year question, exact question. Okay, mountain sickness, what is the drug of choice? Drug of choice is acetazolamide. And where does acetazolamide act? Acetazolamide acts at the proximal convoluted tubule. Right, it acts very good, Muhammad Adil. I'm happy for you. 15 out of 20 correct. Right. Acetazolamide acts on the proximal convoluted tubule where it does not allow bicarbonate to be reclaimed. Right. And that causes metabolic acidosis. And this metabolic acidosis protects a person from respiratory alkalosis. So for this question, what is the right answer? The right answer is proximal convoluted tubule. Okay. Monosomy was there. Okay. Yeah, paternal monosomy, paternal deletion would be the same, right? So what happens is there is a deletion and there is uniparental disomy, right? Paternal deletion and that is accompanied by uniparental disomy. That is Prader-Willi syndrome and it's related to chromosome 15. Thank you, Mohammad Adil. I'm happy that you enjoyed the session. And I think there was one more question on oxyhemoglobin dissociation curve, right? Oxyhemoglobin dissociation curve shifted to the right. And that is because of acidosis. Answer for that question is acidosis. Okay. So that's all for today. I think we have discussed like 22 MCQs. And out of 22 MCQs, other than mucopolysaccharidosis type 9, we had discussed all other MCQs in our rapid revision session. Okay. So thank you all. My best wishes to all of you. I'm sure you'll all come up with flying colors. Good night.